Thank you. Well, it's a real privilege to be here. And actually, I've got some really good experience having come to Australia at the end of last year. So just to put my work into context, really, I'm a physician. I'm not a gynaecologist. So I'm very interested in the whole body. As I explained, I've got a pathology degree. So I'm very interested in disease, but I'm more interested in preventing disease. We've already heard about people living longer. Women are living longer, but they're not living healthier. So I'm very interested in the difference between lifespan and health span. It's not the age we die, it's the journey to that age, of course. Now, menopause has been around for centuries, but it's been misunderstood for most of that time. And it still is now, actually. We're talking about menopause, and I've just heard you talk about how many women might or might not have symptoms. Well, actually, it's more than just symptoms, because these hormones are biologically active that go around our body and affect every single cell in our system. And these hormones are estrogen, progesterone, testosterone. So they're female hormones as well as male hormones, but they're biologically active. So we need to even stop thinking about symptoms. We need to be thinking about the health risks, because we know from very well established research that the longer a woman is without her hormones, these three hormones, the greater the risk of chronic diseases which are impeding women's health. And these include cardiovascular disease, dementia, osteoporosis, clinical depression, and actually different cancers as well. So we need to be thinking about, why are women not accessing treatment? 100% of women will become menopausal, and when their hormones are low, they are low forever. But many, many women experience symptoms before menopause, during perimenopause, or they have PMS, premenstrual syndrome, or PMDD, premenstrual dysphoric disorder. And those symptoms can be worse than menopausal symptoms. But actually, whether women have symptoms or not, they still have health risks. We know globally only around 5% of women are receiving an evidence-based treatment. We wouldn't be having this conversation if we were talking about underactive thyroid disorder or raised blood pressure, which, as you know, raised blood pressure is a risk of heart disease. We know for the majority of women, HRT, the body-identical hormones, the natural hormones, the same structure as our own hormones, have more benefits than risks. Yet in Australia, I'm hearing it's more expensive to get these natural hormones, which seems really unfair. A lot of the work I do in my organisation, which isn't funded externally by anyone, I don't work with any pharmaceutical companies, unlike many menopause specialists. We give a lot of money out for a lot of outreach work. We're doing a lot of work talking to women, reaching women, helping women who cannot afford evidence-based treatment. I've developed the Balance app, which has 1.4 million downloads globally. I have a podcast which has had nearly 7 million downloads, and 20% of those listeners are Australian women. And every day I receive messages on my social media from women from Australia telling me how hard it is to receive evidence-based treatment, yet it's quite easy for them to receive antidepressants, which have long-term risks, as I'm sure you're aware. They're addictive, but also there's a risk of osteoporosis with them. We need to be waking up and having really grown-up conversations about, why are we denying evidence-based treatment? As a holistic practitioner who wants to reduce disease going forward, I can't understand why this conversation is happening in 2024 when we know that we've got safe, effective treatment. Women are being medicalised for menopause with antidepressants, with painkillers, with sleeping tablets. They're being mislabelled with conditions such as fibromyalgia, chronic fatigue, and it's really impeding them. Personally, as a menopausal woman, I would not be working as a doctor if I wasn't taking hormones. But I also take hormones because I'm very scared of osteoporosis, which affects 1 in 2 women. I have seen and doctored enough women with osteoporosis of their spine to know how uncomfortable and painful and disabling it can be. So it's an individual choice, but the problem is globally, including in Australia, women are not given a choice about treatment. So we can talk about everything else, we can talk about gender inequality, but actually we need to be talking about, why women not being given an evidence-based treatment, especially when some of the narrative is coming from people who do have their own agendas, or they have conflicts because they're paid for by other organisations as well.
And thank you to our international friends that have come to speak to the committee today. I do want to highlight that your work has already been recognised by some of the witnesses to our committee for really offering them a lifeline and significant support. So I wanted to start by asking Dr. Newson about international collaboration on these issues, what we learn from, for example, health surveillance data across jurisdictions. And I note you've got an app, and I just downloaded it while you were speaking. As a perimenopausal woman who takes hormone replacement therapy herself, I thought, okay, well, I'll have a look at that. I'm sure that the NHS has a different version of these issues, but there's a proliferation of apps and the things, and symptom trackers and the like. And I note that our own digital health agency is starting to look at having health identifier numbers and really to look at which accredited apps, etc., might start to connect, could intersect into that system. And I guess I want to ask you what the future could look like if we're really able to use data to tap into the diversity of women's experiences, as well as their symptoms, their treatments, and really make a difference in terms of finding out what's working best.
Yeah, that's a really interesting question, because digital health is the way that things are really going to go forwards. You know, there's 1.4 billion menopausal women. There's a lot more perimenopausal women. We've already heard the problems with women who are younger, who are menopausal. So it's about 1 in 30 women. And a lot of my time is spent working out how to reach women who I'll never meet, who I'll never come to my clinic. And so that's why Balance is free. It's not got any external funding at all, and it's always going to be free. But I've been a medical educator. I've been a medical writer for the last 25 years. So a lot of my work is about writing evidence-based information. So the app has a huge amount of information on it that we're constantly improving, uploading, making more up-to-date. It's in conjunction with a website that we run as well. And these resources have been invaluable for women. It's also about giving people a choice, as I've said. People can monitor their symptoms if they want to, but also they can think about their physical health, their nutrition, their mental health, because it's very holistic menopause care. Some of this conversation is about whether we take hormones or not. Even though I say I take hormones, there's no point me never doing exercise or not eating healthily. Of course, that's not going to be good. So we have to think in a 360 degrees, looking at everything. So people really enjoy being able to take part in different experiments to reduce sugar, to do more meditation or what have you. And that can be accessed from countries even when they don't have menopause treatment available to them, which has been really important. We found from doing some research on users of the app that women are more empowered. They feel more able to receive treatment, they're more vocal, because what's happening so much is women feel knowledgeable about information and they want to receive treatment. Then they go to their healthcare practitioner and being told, oh no, you've got something else going on, or let's give you some antidepressants, you're depressed. Whereas if they've got more information, they can have a really good shared decision-making process, which is so important when we're thinking about choice and future health, because we have to remember, for most of us, our menopause, hopefully, if we live long enough, will last about 30 years. But if I was 25 or 30, or my youngest patient was only 14, her ovaries never developed properly, the majority of her life will be. So it's crucially important that women make the right choices for them, and know that they can change their choice of treatment at any time as well, which is so important. And I've been doing a lot of collaborative work with Professor Kulkarni, who I know you've heard from earlier today.
Yes.
And the mental health component of menopause is the one that scares me the most. We know that gynecologists traditionally have been looking after the menopause. When you look at the definition of menopause, it's about loss of periods for a year. I'm not interested about periods or whether I'm fertile or not as a menopausal woman, but I am interested in my brain. And even, I know it's this morning, so yesterday for me, but earlier in the day for you, I did 2 consultations yesterday. One who's a lady who's planned her suicide. She's 47. She's been fit and well. And she, her husband phoned in and wanted an emergency appointment. Her whole life has been taken away from her. She's got 2 teenage children. She can't concentrate. She can't think. She has very negative thoughts. Another lady I saw is in a psychiatric hospital being sectioned, and I went and visited her a few months ago, and she'd stopped her HRT because there was a shortage over here, and she then tried to take her life by jumping out of a window. These are not just occasional stories that we hear. We know suicide increases by a factor of 7 in women in their late 40s, and a lot of it will be due to hormones because we know they work as neurotransmitters. So we need to be having really grown-up conversations. I am not interested in the number of people having symptoms. We know the majority of women actually do have symptoms, but when the symptoms are the ones that are affecting our brain are the most common symptoms, it's not about flushes and sweats. And so that's really important when we're thinking about mental health, but when we're also thinking about workplace. We know from surveys we've done in the NHS as well as other workplaces that the commonest symptoms affecting women are symptoms affecting our brain. And so it's memory problems, anxiety and fatigue. So we can't just be saying to women, reduce your hours or change your uniform or have a fan. I'm part of the government menopause task force over here, but we still need to be having grown-up conversations about how can we enable women to work and allowing them to have the choice. We know HRT prescribing has more than halved since 2002 without any reason, because this study actually was looking at older types of hormones and the risks were very, very small. Yes. And estrogen only is associated with a lower risk of breast cancer, as I'm sure you know anyway. So we need to be thinking about access to treatment in all countries.
Thank you, Dr. Newson. That was very compelling. Can I ask you both about the debate around bioidentical hormones and the diversity of them? Yes, there are limitations in what we can get through our medical systems and our pharmaceutical benefit systems. In Australia, some are on script and some are off script, as I'm sure you're aware. But I get concerned that this debate about whether bioidentical stuff is called better or not better starts to get conflated with the historical risks around HRT, and I would really like some of that unpacked.
Yeah, it's a great question and really important for people to understand, and a lot of it is just words, which then causes a lot of confusion. So our hormones, the estrogen, the natural, the most anti-inflammatory type of estrogen is estradiol. So there's estradiol, progesterone, testosterone, and I've already said they work on every cell all around our body, and they're biologically active, so they affect the way our cells work. They improve all the chemical reactions that occur in every single cell, and they can have genomic changes as well, so they can affect and improve the way our genes work. Now, in the past, when HRT was first devised, as I'm sure you know, it actually came from pregnant women. That was very expensive to manufacture, as you can imagine. So then they turned into using it from pregnant horses. But pregnant horses' urine doesn't just contain estradiol. It contains all sorts of other things, but they put it into a tablet. And then women who have a womb, they gave a type of progesterone, but it was a synthetic progesterone. It was actually medroxyprogesterone acetate, which has been chemically altered. So not only will it block the receptor for progesterone working, but it won't have these lovely chemical reactions that occur. So it's like comparing apples and pears, or even apples and bananas, and saying all fruit is yellow because bananas are yellow. They're very, very different chemical structures. And that's really important. What is quite ironic is that the synthetic progestogens are all in the contraceptives. We don't have this conversation. But so now, moving forward to 2024, we have these natural hormones. So biochemically, they're exactly the same structure as the estradiol, progesterone, testosterone that we produce ourselves. And the best way of having estradiol is through the skin as a patch or gel. There is a spray, but it's not very reliably absorbed in our huge clinical experience. Yeah. And I must add, we see about 3,000 women a month, so we have a lot of clinical experience. So the patches and gel are best because they go through the skin into the bloodstream. They don't get metabolized by the liver, so there's no clotting risk. There's less, they don't get metabolized into other substances. They're very safe and the dose can be individualised. We have the natural progesterone, which can be given orally or vaginally. And then the testosterone, again, in Australia, it is licensed for women, but it's not in any other country. But that's usually given through the skin as well, because there's no risks. Now, so there are some people that talk about this compounded bioidentical hormones, and basically that means that it's not under the same regulation as in over here it's our Medical Health Regulatory Authority, MHRA. But we are very limited in what we can prescribe. In America, for example, it's really hard to get testosterone unless it is compounded. Now, there are different compounding pharmacies. Some are better than others and some are more regulated than others. And actually, it should be quite cheap, because the whole problem with a lot of this, and I think a lot about why has it got to such a state, is because these are natural hormones. They can't be patented. They're very cheap. Pharmaceutical companies are not interested in natural hormones. And so if you have a good compounder, like a lot of my colleagues in America do, it's still very cheap for women. Yeah. There are clinics, private clinics, that have set up all over the country, especially after the fallout from the WHI study, that have been marketed as this individualization, lots of blood tests, very expensive. And I've seen women who literally spend thousands and thousands of dollars equivalent on these compounded bioidentical hormones, which is wrong, because we've got these natural hormones. But we should, as healthcare professionals, have more training. And that's part of the problem, is that medical students, junior doctors don't have training when it comes to menopause care and safe prescribing of hormones. I do a lot of work with psychiatrists, rheumatologists, neurologists, cardiologists. All of these should be prescribing hormones as well. It shouldn't be left to primary care physicians or to gynecologists as well. But if we understand the basics, and it is quite basic, then it all makes a lot more sense.
That does make sense to me. I started arthritis treatment using Cimzia before I started hormone replacement therapy, and I may not have needed the Cimzia. Perhaps, should I have lined those things up differently? So can I ask what all this means? Can you also add a discussion about testosterone? Because some people get really alarmed at the idea that women...
It's very interesting conversation. It's very interesting conversation. And, there's lots of people have their own... views about testosterone. But if we just go back to basic physiology, testosterone is a hormone that all women produce. We produce it from our ovaries, our adrenal glands, but also from our brains. So all three of the hormones that I've mentioned actually are neurosteroids. They are produced and manufactured in our brains. And testosterone is actually made from progesterone, and then it's aromatase into estradiol. So it's a very important hormone. It's biologically active. It's the most biologically active hormone we have. And when we're young, we produce more testosterone than estrogen, but it declines with age. So it's not really a menopause-related decline, it's an age-related decline. If someone has their ovaries removed, then at least 50% of their testosterone just goes with their ovaries. So people who have a surgical menopause often have quite severe symptoms, more than a sort of natural age-related menopause, and often their testosterone goes very low. We know from even some studies from the 80s that when women have had their ovaries removed and they're given estrogen and testosterone as opposed to just estrogen, they have a lot better, less symptoms, especially brain-related, so cognition, mood, and energy symptoms. The problem is all the studies have been done looking at libido. And so now the guidelines say we can prescribe it if women have reduced sexual desire despite being on HRT. And in our clinic, that's how we prescribe it. But we're constantly monitoring everybody's symptoms, all their symptoms, not just libido. And we find that symptoms of mood, energy, concentration, stamina improve, as do many other healthcare practitioners who are prescribing testosterone. But we also know it lights up our brain. We've got receptors in our bones, in our heart, in our cardiovascular system, in our muscles. So, of course, it makes sense that it's going to help improve. Just because the studies haven't been done, it doesn't mean it's dangerous. And you could argue, well, it doesn't mean it's safe, but actually it's a natural hormone. What are the long-term studies for giving someone quetiapine or citalopram, an antidepressant? Now we're seeing people who have been given ketamine infusions. There's no evidence for that long-term safety. Whereas, again, if if we don't have evidence, medicine is an art as well. We individualise care. We allow women to make a choice. And actually having a natural hormone, as long as it's given in a proper way and is monitored, because we do see women who come from other clinics, or they're so desperate that they order it online and they're not giving themselves the right dose and it's not being monitored. But in our huge clinical experience, we do not see side effects. We do not have hairy patients. We do not have people with deep voices, but we do have people who can get back to work, who can function at home, who are enjoying their life. And that is really important. But the other thing is we have a lot of patients who can come off their psychiatric medication, their biologic agents, their blood pressure treatment, their statins. So we do a lot of de-prescribing as well, which is really important.
Thank you. That was, really important evidence. What can you tell us about the difference between prescribing in the UK versus here, and what in the context of all the regulatory issues and the health systems issues and the medical debates about what's ethical and what's got efficacy, what does that mean for us as legislators trying to push our health bureaucracies and regulators in the right direction?
I think it's really important. I think it's really difficult for non-clinicians or people who haven't read all the evidence to actually make big decisions from top line and from people that are saying different things and have their own narrative. I think one of the most important things is to be really transparent and look at anyone's agenda. Everyone in any aspect of life has their own agenda. My mission is to improve the health of women. I have no affiliation with any pharmaceutical companies, like I've already said, which is very important because there are non-hormonal treatments coming to market, which I really worry about because there's no long-term data about their safety. But we do have long-term data about hormones. They were first discovered in 1920. So we've got, 100 years of data about how healthy women are. But we also have data about how unhealthy women are in their last decade or so of their lives. We're able to prescribe any contraceptive very easily. A lot of contraceptives block our natural hormones working, and they have more risks than our natural hormones. So one of the things that we all need to do in every country is to distinguish between the natural body identical hormones and the synthetic hormones, because they are completely different. That's causing a lot of confusion to governments, to prescribers, to women as well. And even if you look at, I'm not sure if I'm allowed to mention the word vagina in this meeting, but vaginal symptoms occur in around 80% of women. But it's not just some soreness when they have intercourse. Actually, a lot of women I see can't sit down, they can't wear underclothes. But more importantly, they have recurrent urinary tract infections. And around 30% of sepsis is due to urinary tract infections. Vaginal hormones don't get absorbed into the body. They're very, very safe. So they can be used for women who've had breast cancer, including estrogen receptor breast cancer, whereas we know the minority of women are receiving them, but the warnings that come with the packaging will say risk of clot, risk of heart disease, risk of breast cancer. So of course people are going to be scared. So the most important block with this is education for healthcare practitioners and misconceptions and myths, and we need to demystify. I spend a lot of time making quite complicated medical literature into, words of short sentences that people can understand, and I've done that for the last 25 years in a myriad of topics. And menopause is no different, but it's become so political, and it shouldn't, because it's very simplistic medicine. It really is, and it's transformational medicine. I went into medicine to help people feel better. All my patients feel better because they're getting their hormones back. But more importantly, I know I'm investing in their future health and reducing their risk of diseases. And we've got evidence for that. Even in 1972, there was a meeting showing that menopause treatment does more than improve symptoms, especially for bone health, osteoporosis, but also heart disease. And it's, most women die from cardiovascular disease or dementia. So we need to be thinking about, why are we refusing a treatment that halves risk of cardiovascular disease? Like, it doesn't really make sense if you think about it in a very, unemotional way, if that makes sense.
of those. I know my time is about to go, but I've just got one quick question for Dr. Newson, based along the same line in regard to the handout that you just emailed back through a short time ago. You're talking about a menopause education program for healthcare professionals, downloaded by over 33,000 clinicians globally, which is an amazing outcome. Just wondering, how old is that, and is it regularly kept up to date, and do you know if that's being used here in Australia, is another question as well.
Yeah, for sure. So I set it up a few years ago. Actually, I was heavily involved in the Davina program, which has exploded menopause care and improved it over here. So, but I set it up and I videoed consultations because most of my knowledge and experiences come from real life situations. That's how you learn best as a clinician, but linking it to evidence. So we video different consultations and we link it to evidence, to guidelines, to patient resources as well. It's recently been updated with a team because now I've got a bigger clinic. I can afford to spend more money on education. So it's constantly updated. So any new evidence we will put into that, any new resources we put into that as well. It is 90% can be used by any country, and we do have people from many countries, including Australia, who have downloaded it and use it with amazing feedback. What we want to do is get more resources so that it can be individualised for each country, which will make it even more easy. But it's very cheap, it's very accessible, it's online. I've spent so much time and money in the past going on courses where I haven't felt that I've learned. But also it means that you can really, if you want to choose a patient who's had breast cancer or a more complicated patient who's maybe got different diseases, you can choose from that, which is really important because you might sit in someone's clinic and not see anything that's relevant for your practice. So it's a very time-efficient way. So I have a team of people, but nurses and pharmacists. So we shouldn't just be talking about doctors. We employ nurses and pharmacists, and actually prescribing pharmacists and nurses can be really, really important when it comes to menopause care.
Professor Dr. Newsom, thank you for your wonderful extensive evidence before, and we had a lived experience person in before who particularly noted you and noted how helpful you had been in her journey, so I just wanted to pass that on. You've got a lot of supporters here in the inquiry. I loved your emphasis on the mental health impacts of perimenopause and menopause. I think that was well covered. So with the dwindling time, I was just interested in the interaction of perimenopause and menopause and two things. One is neurodivergence, and any observations that you've had from your clinical experience about what interaction there is. And the second one was a note that you had in your sub where it said 67% of people claimed that peri or meno increased domestic abuse. And, you know, we do a lot of work on violence against women on this committee and broadly as well. So I'm interested in your views on what impact peri and menopause can have on that as well.
Really important, both questions. So neurodivergence is really, really important. We see a lot of people who have either been diagnosed in the past with ADHD, for example, that gets worse, or it just starts, the symptoms start during perimenopause. And as you know, our brain likes homeostasis. It likes things very well controlled and calm. It likes the same. So if you've got a chaos of hormones, and often our hormones are going up and down and really fluctuating in the perimenopause, or with women with PMS and PMDD, then that can trigger various cascade of problems in the brain. But also our hormones, as I've said, are neurotransmitters. So they affect the level of serotonin, dopamine, glutamine, really important neurotransmitters that we know have a role in neurodiversity as well. When we give hormones to women, we find, especially actually with testosterone, but also progesterone is a very calming hormone, the right balance of hormones to the right person can really improve those symptoms. And it really worries me because there's an explosion of diagnoses, as you know, in all countries actually of ADHD with amphetamine-based medication that has been given. But actually, again, treat the underlying cause and then see what's left. And I have patients who do need medication as well, but actually it can be transformational having hormones back. And a lot of women who I see, increasingly I'm seeing a lot more women who are more testosterone deficient than estradiol and progesterone deficient, so they're still having regular periods. They have testosterone with small amounts of HRT, estrogen and progesterone, and they say, I wish I'd started this years ago because my brain is calmer, I can think clearer, I can process better, which is really important. With your question about domestic violence, it's crucially important. There is limited research, but there is some research to show that women who are subject to domestic abuse, whether it's physical or emotional or both, are more likely to have menopause at a younger age, but also more likely to have more severe symptoms. And a lot of the symptoms of low self-esteem, reduced self-worth, feeling dreadful, feeling tired, having reduced libido can be an absolute delight for someone who is abusing that person, and that can make that person feel worse as well. Our bodies are very good at stopping us being pregnant under difficult situations. So if we're under a lot of stress, if we lose a lot of weight, for example, if we have an eating disorder, but also if we use drugs to excess. So a lot of drug abusers will have menopause at a younger age. And I've been doing a lot of work in prisons recently. And most women I've spoken to in prison are actually women who have PMS and PMDD. We know since the 60s women are more likely to commit a crime in the days before their period if they have PMDD, because they can get more irritable, more agitated. And I've spoken to lifers who have killed someone. The day after their periods come, they've regretted their crime. But they're now in for life. They're in their 50s. They're clearly menopausal. They cannot receive HRT because the prison doctors aren't trained in menopause adequately. So they're given gabapentin, pregabalin, antidepressants, antipsychotics. They all have street value. And when you talk to them, and even the younger ones, they're saying, but my period stopped 5 years ago. I didn't really connect it, but I've got dry, itchy skin. I'm sweating every night on a plastic mattress. I can't open the window because the person in the bunk below doesn't want it. My brain doesn't work. I can't think. These are menopausal symptoms as well as symptoms related to what's gone on in their trauma in their past. But it's about labelling of women. And I've already heard, obviously, in workplace, women are being labelled. I don't want a label. I want to feel better. And I think this is really important, what we're doing in a larger section of community, because I just think, for example, if I broke my leg in work, I would like someone to recognise my broken leg. Or if I broke my leg at home, I'd want my children to call an ambulance. But I would want treatment. And then I could go back to work, maybe on limited hours initially as my leg was healing. But then I want to be a best version of myself. So many women in the workplace, at home, under very difficult situations, especially in areas of deprivation. They're being blamed for their culture, their society, the way they live, their eating habits, their alcohol, their whatever. But actually, without hormones, it's a catastrophic disaster for these women. So we need to enable us to think just more widely, thinking about why are we denying hormones when these women are being told that they need to reduce their hours, when they're not allowed access to treatment. It seems like we're going back in time to the 30s and 40s, really. And I'm not here saying everyone should be taking HRT, but I am here saying everybody should have choice. And those people that want to take hormones should be able to. And whether it's 10% or 100% of women is irrelevant. But at the moment, every day from women across the world, I hear from women who are unable to access safe and evidence-based treatment, and that's the real problem.